But we have an incredibly interesting and expert panel, which I will introduce to you, if I can push the buttons and the slides go. Here we go. Do we have the next slide?
I know, right?
There we go. So it's a very distinguished group. I will give a little background. You know, an expert is defined as someone from far away who shows PowerPoint. So I will pretend to be an expert today and try to provide a little background, and then ask each of our panelists to tell us in a brief time on the first round what they do and how it fits into the general scheme of what we're all interested in, improving health in this country and everywhere in the world. And one of the questions I will ask them thereafter is what really keeps them up at night? What are the issues that we need to worry about? So a little background given the nature of the panelists. And this slide was perfect up until this morning. Because the question is, how long can people live? What is the expectation of the limit of life expectancy, and what are the consequences? And as you can see, all the little bars to the right are predictions of great experts in population of the maximum age that people could survive to. And in general, what you see, it's a perfectly straight line. It has gone up every year for many, many years. And there is no known limit, at the least from statistical projections, of how long people are likely to live. The New York Times this morning says that if you're white and in the United States of low social income, your life expectancy is starting to drop. And I think that's likely to be the case with diseases of affluence elsewhere. The consequences of that, and what there is tremendous expertise on the panel, is what happens to the nature of illnesses when we keep living longer. And as you can see, as the orange lines of communicable diseases go down, at least as we know them, non-communicable diseases, heart disease, cancer, neurologic disease, mental health illnesses are increasing, and that's a changing dynamic, not just in the US and the rich countries, but in the poor countries as well, for which they're relatively poorly prepared. This slide simply says that the US spends almost half of all the global expenditures on health in one country. The developing countries' contribution in the global expenditures is about 13 to 15%. So there's a big disparity in the funds that are spent, and yet even in this country, the issue of equity and lots of people who don't have access to health care on a regular basis, or health security, even more importantly, is quite huge. And again, disparities between states like Texas, where 25% of the people have no insurance, versus my state, where almost everybody has insurance coverage. I'm sorry, let me just go back one, if I can. Oh, sorry. How do we go back? Yes. Relevant point for much of this is that if you look at Medicare data from 1980 to the present, we're spending $2.7 trillion at the moment, but between 28 and 32% is on people who will be dead within a year or two. And one could ask whether that's the appropriate way to spend even unlimited resources, let alone limited resources. And when you look at to whom we devote those funds, we find that basically 1% of the population contributes or costs 25% of all expenditures, and 10% costs 64% of all expenditures. So it would be very simple if we knew who those people were and to do things that are preventive, but at the moment we don't. And the consequences of not, and since the title of this session had something to do with budget, the reason people worry is that the budget keeps going up and up and up for health, and unless we do something quite drastic, even in this country, let alone in every other country, the problem of paying for the new technologies and new advances in science is a universal one. And that gets us into another aspect of this program, which is how do we think of new ideas, new technologies, new approaches, innovations in a very disparate world. Tom Friedman is wrong. The world is not flat when it comes to health. And this is just a chart that shows the size of the countries is the diameter of the circle, and the blues are almost all sub-Saharan African countries. And the rich countries are at the right, and you'll note with all the money we spend, we are not the healthiest, at least in terms of life expectancy. So the big picture is all systems produce the results that they're perfect results that they're designed to produce. If we want to change the results, we need innovation, which is what this meeting is about. And we have to change the way we do things. One part of that is adding new things to the system, and another part of it is fixing other parts that exist. For example, using tools that we know and achieving greater global equity. So with that brief background, let me ask each of our panelists to tell us what they work on and how it would fit in to making this a healthier world. So please.
Thank you, Dr. Bloom. My name is Todd Evans. I'm a developmental stem cell biologist at Weill Cornell Medical School. And I work so I'm a basic scientist, but I work in a clinical department for translation to hopefully try to cure diseases. The diseases that Dr. Bloom mentioned are diseases of the elderly, which means that two things. First of all, the population tends to be, as we age and as these diseases become more prevalent, are spending a larger portion of their life suffering. And in addition, we're spending a larger proportion of our healthcare dollars basically to extend unhealthy life rather than to extend lifespan, which is unhealthy life, rather than to extend healthy life. And this brings up the concept of a health span rather than a lifespan. So, there's one issue, which is whether we should be allocating certain resources to extend unhealthy life, and that's not an issue I'll address. It's a policy issue. In terms of a scientific issue, the question is, what can we do to extend health span? Now, the bad news is that we're all going to die, and there's really nothing we're going to be able to do to solve that. But I don't think probably anybody really wants to live forever. You wouldn't certainly want to live to be 150 if, in fact, you're debilitated when you're 50. And so, to put it in a more practical sense, probably you'd prefer to live to 90 and die a healthy person than even to live to 100 if you're debilitated with a degenerative disease starting when you're 80. And so the question is it possible to extend that health span? And I think there are two points that I'll make that indicate that it's possible. This is based on our understanding of developmental biology and the role of stem cells and progenitor cells. So these are organ-based diseases. These are degenerative diseases. Degeneration is the failure to regenerate. Now, during normal development, organs are formed from stem and progenitor cell populations. So we understand how the organ is formed. And the hypothesis is that the failure to keep regenerating these organs is due to the failure of a stem or progenitor cell population to maintain its regenerative stem cell capacity. So the two areas of research that I'm involved in that I think have some can impact this are, first of all, trying to exploit what we understand about regenerative capacity. So we have regenerative capacity, natural regenerative capacity. But it's different for different organs. So your skin regenerates very well. Your liver, as Prometheus knew long ago, actually regenerates very well, in fact, on a daily basis. Our organs are normally turning over. Other organs regenerate very poorly as we age, for example, the heart or the brain. However, so we know that there's different capacities, and if we understand those different capacities, we may be able to apply what works well in one organ system and not so much in another. Second of all, some species retain regenerative capacity that we don't have. So, for example, amphibians and fish have amazing regenerative capacity. They evolved to retain that capacity, probably from getting their limbs chopped off, chewed up all the time. So, and what's really amazing is that, so if you take a zebrafish and you chop off its limb or its fin or chop off part of its heart, it grows back perfectly normally and is functional. And what's really amazing is that it does so by using stem and progenitor cells that were used, and genetic pathways that were used to form the organ in the first place. Those are the same genetic pathways that we still had because we used them to form our organs in the first place. So we presumably still have this innate, robust regenerative capacity, and we need to understand why it's repressed for some of our organ systems. And second of all, my last point is that there's good evidence in humans that there is the genetic capacity for maintaining regenerative robustness. So there are actually clusters of humans, for example, certain Ashkenazi Jewish populations that live to be over 100, and it's not because they just live long, they live healthy long, so they have a long health span, and this health span is inherited through generations. And so just as you can inherit genes that give you poor health, you can inherit genes that give you good health. So by looking at animal models that, in fact, can give us hints on how to increase robustness of our regenerative capacity and the human genetics that actually have evolved to do it, I think there's hope to translate that to treat these diseases for greater health span.
Let me then turn next to Dr. Lemishka, who is one of the pioneers in developing stem cells, and ask him to give us a perspective.
Okay, thank you. I don't know about 150, but a healthy 120 would be nice. So I've worked in stem cells for probably, close to 25 or 30 years. The first part of my career was at Princeton University for 21 of those years, and about 5.5 years ago, I relocated to the Mount Sinai School of Medicine. Basically, my research interests have all been in mammalian stem cells, and I'll give you some examples of some human research that we've been doing. But I started off in the blood-forming or hematopoietic system where, and this is really sort of getting back to a little bit, dovetailing with what Todd said, it's a really truly remarkable system because all of your blood comes from individual cells in the bone marrow, and blood is produced every day at an amazing clip. I mean, we make billions and billions of new blood cells every day throughout adult life, and they all come from these rare hematopoietic or blood-forming stem cells that are located in the bone marrow. And kind of to give you an idea, somebody once did a kind of a funny back-of-the-envelope calculation that if you averaged up or added up all the new blood cells that are produced every day throughout life of, say, a 70-year-old adult throughout the entire life, and you packed these cells together, got rid of all the liquid, then that volume of cells would be enough to fill up a hollowed-out body of a 747 airliner. So it's really a truly remarkable regenerative system. And in fact, we've all heard about bone marrow transplantation. Widely used therapy, and this is in fact a stem cell therapy, and I think in many ways serves as a paradigm for the whole field now of, everybody talks about stem cell and regenerative medicine, so on and so forth. Currently, why I moved to Mount Sinai was because, I mean, I was very happy at Princeton University, but having said that, I felt that given that Princeton has no medical school or medical institution associated with it, I felt very strongly that to move my research into the human system and perhaps into areas that might, in the foreseeable future, benefit mankind, I really needed to be somewhere with a major medical institution like Mount Sinai. Which then leads me to the second point, and what I would like to tell you about now is an area of stem cell research that's fairly new, probably about 6 years old right now, which promises to be a true sea change in biomedicine. And I'll actually try to give you some examples, tangible, concrete examples of what I mean by that. So there's a technology now called induced pluripotent stem cell, or IPS technology for short, which allows us to make pluripotent stem cells, which I'll define in a moment, from skin cells or other cells from any individual in this room, and we can do this easily and we can do this quickly within a matter of months. Now, what are pluripotent stem cells? Pluripotent stem cells can be coaxed. They can be grown forever in a dish, and they can be coaxed at will to produce any of the 220 or so cell types in the human body. So imagine that. I mean, we can take skin cells, convert them to a pluripotent state with a simple cocktail of proteins, and then we can make blood cells, we can make neurons, we can make heart cells. Now, I think the mistake that many people make is when they think about stem cell therapies and stem cell-based therapies, you immediately think of replacement cell populations or replacement organs that could be used in transplantation. And I'll give you some examples where I think the reach of stem cell research and its promise are much, much broader. So imagine, if you will, that if you have a particular heart condition. Now, how would one go about trying to define or develop drugs that, or pharmaceuticals that might be useful for treating your particular heart condition? Now, everybody in this room is different because of genetics, and therefore, by definition, everybody who has a heart disease or would have a heart disease, that disease has similarities, but it's also different. And in fact, there are examples where for cardiac arrhythmias where two different patients with essentially the same disease are given the same drug, and in one individual, that drug has beneficial effects. In the other individual, that drug actually exacerbates and makes the disease worse. So why is that, and how can we move forward to actually developing pharmaceuticals and drugs and diagnostics that are tailored to individual people? So if I take a skin cell from somebody with a heart condition, make an iPS cell from that, and then coax that iPS cells to make heart cells, cardiomyocytes or cardiac muscle cells. And you can make these at will. You can make these in volumes or numbers as high as you want. And then you have these cells, heart cells, and you can do two things. So because you can coax these iPS cells through different stages in a dish, you can watch how these heart cells actually develop or differentiate, and therefore you might then be able to ask in an in vitro, what some people have referred to as disease in a dish models, you are in a position to ask, at what point during this development from iPS cell to heart muscle cell, where do I see the first hints of something going amiss, right? And so understanding the etiology of diseases is now feasible, and it's feasible if for no other reason than even if one is able to obtain a heart biopsy from an individual, these cells don't grow. So they're of limited value in terms of developing drug discovery platforms. Now, with iPS cells, we can make as many heart muscle cells as we want. And then what an academic like myself can do is think about partnering with a pharmaceutical company and saying, hey, you folks have access to many, many compounds or potential drugs. I have an ability to model in a patient-specific manner a complex disease. Let's partner here and see what we can do. And this is, I'm giving you the cardiac example, but it's true for psychiatric diseases. One can, a colleague of mine at Mount Sinai, Kristen Bernard, who a new recruit, has modeled schizophrenia using iPS technology. So, and think about that. I mean, what do people that study and treat schizophrenia, or the genetics of schizophrenia and autism, what do they have? They have, on the one hand, extraordinarily complicated psychiatric pathology or disease, and on the other hand, if they're really interested in studying the genetics, they have DNA samples from these patients. But there's nothing in between. I mean, obviously, you cannot biopsy a brain to look at neuron defects in schizophrenia. Occasionally, you can get a cadaveric brain from a deceased person who had this disease. But now we can make iPS cells. We can coax these cells to generate many different kinds of neurons, nervous tissue in vitro, in numbers that are unlimited. So here we have the potential of asking now what is the cell biology of a complicated psychiatric disorder? So these are two examples of, I think, where this induced pluripotent stem cell technology is revolutionizing and promoting a true sea change in medicine. And in fact, it's much harder to think of an area of medicine that cannot be or will not be impacted by this technology than it is to think of applications that will. And I'll leave it at that.
Thank you much, Lee. I'm going to jump next to move from the very, very basic of regenerative medicine and gene development to the circumstance where the genes are developed in a person. And I'm going to ask Larry Young to talk about what happens when you get a bad hand of genes, and how does one think about that?
So my name is Larry Young. I'm a professor in the Department of Psychiatry at Emory University, and I've been working for the past 15 years trying to understand the basic neurobiology of social behavior as it relates to diseases like autism and schizophrenia. So I use animal models to try to understand, how do you go from the genes to brain and behavior. And that's really important for diseases like autism, where one of the primary problems is the ability to interact and to relate with others. And I also am interested in many other different kinds of psychiatric disorders and concerned about how do we go about developing new drugs for treating these disorders. And in 2010, I established the Center for Translational Social Neuroscience because I realized that the work that I'm doing in my lab is only, looks at one aspect. We really need to get people together that are working at different levels. And so the goal of that center, which I developed at Emory, is to bring together people that are working at the level of genes, cells, neurons, animal models, all the way up to clinicians that are treating disorders, to bring those people together, bring the students and postdocs that are working on these each individual level, bring them together so that everyone can exchange information to get information flow at all levels. Because I think in so many areas in science, you have people that are focused on one individual topic. So that's been my approach. And I've been in the forefront, or among those in the forefront of trying to think about how you might create treatments for diseases like autism, which is incredibly complex. The brain is the most complicated organ in our body, much more complicated than the liver. And most of the drugs that have been developed to treat psychiatric disorders are really the same drugs that have been around for a very long time, or at least they target the same molecules. And drug companies have really run up against a wall in terms of developing new drugs because they don't really have new targets for these disorders like autism, schizophrenia, and even depression. They've been targeting the same drugs. So this is the issue that we have to resolve. And I think that the way we have to move forward with this is, and instead of going with the old model where you have drug companies working on developing drugs for their target disease, and then you have academia where scientists are making discoveries about the etiology of that disease. What we have to do moving forward is to unite those resources of academia and governmental funding agencies, as well as private funding agencies globally, not just within the United States, but globally putting together a concerted effort, coordinated effort to really tackle these disorders. So for example, with autism, you have a group of people that are working with these stem cells. Well, how do you then think about to use those stem cells in the brain of a mouse, for example, to look at how they connect? And then you need other people that are more interested in sort of the neurochemistry, neurotransmitters. That's a different group of people. You need other people that can think about how this might relate to human behavior and how it might fit into clinical therapies. That's another group of people. And if they're all working in isolation, you're going to move very slowly. But if you had some way of bringing those people together, I think that's the way we're going to do it. And I'll just give you one example of where that's been tried that I recently learned about is the Innovative Medicine Initiative by the EU, where they are bringing together multiple different institutions, academia institutions, as well as federal or governmental funding agencies, and also private foundations, for example, Autism Speaks, Simon's Foundations. They're all coming together, pooling their resources to develop a plan that tackles the same disorder at multiple different levels. And I think that's sort of a vision of the future of how to move forward with these very, very, very complicated disorders.
One of the issues that is intrinsic to the discussion of disorders is how do we know there's a disorder, and how do we diagnose what is the genetic or biological problem. So let me turn to Yemi Adesokan, who has been working on using genetic tools at the most sophisticated level to find out how they can reveal early on in diseases or in infectious diseases what the problem is.
Good morning. My name is Yemi Adesokan. I'm the CEO and founder of Pathogenica. Did a postdoc at Harvard Medical School with George Church, one of the founders, if you will, of the Human Genome Project. What I would like to talk about this morning, it will really be regarding three things. One, healthcare costs. The second would be drug resistance, and then really coming down to innovative diagnostics. Over the past decade, in the past decade, we've seen the completion of the Human Genome Project, whereby 10 years ago, it cost about $3 billion to sequence a person's human genome. Today, it costs about, if you will, $2,000, depending on who you talk to. So we've seen a reduction in cost of this innovative technology. But the question remains, how is it applied, especially when you kind of consider healthcare costs? So now let's go to the matter of healthcare costs. Today, we see a problem with the overuse of antibiotics and how this has impacted healthcare costs, particularly in terms of increased hospital stay, in terms of overuse of antibiotics, and when you consider also the spread of hospital-acquired infections. Today we see that the impact of hospital-acquired infections is about really $4 billion to the U.S. healthcare budget. How can we curb the overuse of antibiotics? How can we limit the spread of hospital-acquired infections? One thing that we've seen is the need for new innovative diagnostics, particularly with regards to the detection of drug resistance. So really, what is done today is you go in and see a doctor, and really, you have a cold or what have you, and you're really just bombarded with broad spectrum antibiotics. That is just how medicine is practiced. How can we prevent that? How can we bring in the use of narrow spectrum antibiotics? Well, first, there needs to be a diagnostic method to detect the variety of drug resistances inherent in your cold, in your flu, whatever infection you have. So also this on one side, when you also consider on a global level tuberculosis. Right now, again, the use of just a broad spectrum drug to take care of tuberculosis, when there actually is a lot of drug resistance inherent within tuberculosis, rifampin resistance, what have you. So how can we change the paradigm of the broad use of antibiotics, limit the spread of hospital-acquired infections, and also eventually reduce healthcare costs? So I'll bring this all in context with in terms of genome sequencing as a technology that can be used for diagnosing some of this specific drug resistances. And one more thing I would mention here also, more related to the non-communicable disease side of things, is the human microbiome. We've seen that if you will, we're outnumbered 10-1 in terms of our cells versus microbes within us. And these microbes recently we've seen have an effect on obesity, have an effect on onset of diabetes, have an effect on the onset of Crohn's disease. How can we use innovative diagnostics to monitor our microbiome and see how this eventually impacts our overall health? these are the technologies that have been in development at Pathogenica and some other companies, and we can see how they can be applied to healthcare costs. So I'll just kind of focus narrowly now on the hospital-acquired infections. We're bringing forth a test whereby instead of testing just for MRSA, which has been the norm for years, via culture PCR, we can test for not just MRSA, but Klebsiella pneumoniae, C. diff, and also 15 drug-resistant markers that eventually will be able to guide the physician in choosing the best antibiotic to use in terms of a hospital-acquired infection, but also will be able to track and limit the spread of a hospital-acquired infection within a hospital setting, bearing in mind that 99,000 people die every year because of hospital-acquired infections. After I heard that, I was like, well, what am I going to do when I get sick? Well, don't go to the hospital. But that is not the case. We just need to bring in innovative measures. A question I'll bring forth is, how has this been done over the past 30 years? Well, culture has been around for 100 years. PCR has been around for about 20 years. Now we have next generation sequencing, which gives you a multiplex approach to detect a variety of bugs, a variety of drug resistance markers at the same time. One more thing. We live in an increasingly global community where people are traveling. You could be in Africa, in South Africa one day and be in New York the next day. There's this continual transmission of pathogens across the borders. How do we monitor these pathogens? How do we limit the spread of these pathogens? One thing also that I developed over at Harvard is the BioWeather Map program, whereby you're able in real time to detect emerging infectious diseases, track the spread of these emerging infections through a mash, if you will, of next-gen sequencing and big data surveillance. So these are some of the new innovative technologies from a diagnostic standpoint, from a software standpoint, that we're bringing into place to really reduce healthcare costs, monitor the emergence of drug-resistant strains, and hopefully not allow us to live forever, but at least give us a longer lifespan.
So that really opens up the question of how, in a world that is global, where an infection can travel in a day from anywhere to anywhere else, how do we relate to those countries? You're worried about hospital infections. There are a lot of places that don't have hospitals, but they have infections. They can go to the local market to buy drugs, and that's where drug-resistant tuberculosis, for example, in KwaZulu-Natal, developed so that we can't treat it anymore. And that means having some leverage on and communication with developing countries. And I want to turn to Sheila Ryan, who has done that for a long time, at the ground roots level, where the difference really is tangible.
Thank you, Barry. I'm really honored to be part of this very exquisite panel and share with you from my experience with an NGO out of Washington, the American International Healthcare Alliance, that partners institutions, mostly from the United States, to I think 14 different countries in sub-Saharan, mostly sub-Saharan Africa, with about 45 current projects underway. And I want to share with you what I've learned, what possibly might be innovative that impacts back to Barry's original comments about our systems. See, I've learned from this panel that we're going from stem cell into my way of thinking to systems of delivery and how they are part and parcel of one another. They're not exclusive. And tell a story in Africa about the funding around AIDS and how it relates to now chronic disease prevention and risk reduction of chronic disease that fits with developing countries as well as our own country. When AIDS was discovered in the, not originally discovered, but when we first learned the scope of 45 million people with AIDS, dying of AIDS, at least 3 out of 4 were in Africa, sub-Saharan Africa predominantly. We tracked the patterns of disease transmission, but we couldn't figure out how to get people with treatment or even testing. and that was the real rub. So both Gates and scientists convinced Bush to start the PEPFAR movement, lots of money thrown at Africa to get, the goal was originally 1 in 10 people under treatment, the medication, because if people could see that there was a different outcome than death, they might be more willing to get tested. That was the assumption. And now it's shifted from getting actually medication available, getting it distributed, finding out that now we have some more testing. Oops, we need to have labs. Recently in Tanzania, they upgraded all of the labs to current standards, I think 20 of them. But do they have education for lab pathologists? No. So that's the next step. So now it's under the guise of capacity building. But I was in Johannesburg last year, and I saw a skit put on by a little acting troupe, the arts, who go around to the different schools. And it taught me more in that one session than all of the last 10 years of tracking the funding, even though those were about system improvement. What they showed was the interplay around a family. And most of the men leave to work, they come home, they bring the AIDS back home. They oftentimes bring the AIDS even to their nieces and nephews, nieces who are living with them because the aunt died. There's only one left, the mom. She has AIDS but doesn't know it and can't get tested because he won't let her. And he won't let her because of gender inequity, loss of empowerment, loss of status. So all of the strategies we're approaching have value, but they're not getting to the core issue, which is gender equity and figuring out ways of empowering women. Now that ties in with chronic disease and risk reduction and the use of our exorbitant expenditure of resources on fewer and fewer people. Chronic disease in our country is, I look at the 5 big sources all the time, and we're now seeing that they're growing in all of the developing countries as well. It's diabetes, it's hypertension, it's cardiovascular disease, it's asthma and chronic respiratory disease, and it's depression. It also is mental health. None of these are oftentimes by themselves. Most people, and certainly the longer we live, have comorbidities. And the disabilities that come from that is not from some disease that some stem cell is going to fix. It's from living with all of these counter-interactive problems. So one of the proposals that I have, not just me, but want to share with you about the AIHA twinning projects that have to do with these partnerships that are building pharmacy information centers. They're building learning resource centers to make knowledge and skill sets available to their providers. They have to do with teaching beginning level social workers. Just 1 year of the Jane Addams School in Chicago is out in multiple countries. And they're creating what I call health workers that are village-based. And I think the emphasis on the health risk factors of these 5 diseases have to do with lifestyle changes, has to do with healthy nutrition, better activity or muscle tone. It has to do with stress reduction. It has to do with communication and how well we communicate, and interpersonally, what our dynamics are. And it has to do, what is my 5th one? It has to do with addictive behavior. Those behaviors that are over the top, that don't have to do with balance. And many of them have compounding. Now, how do you do this? Do these people go to a doctor's office to get it done? No. Do they go to the hospital to take care of these problems? No, we need neighborhood-based centers that are focused on health and data building to demonstrate it. Even in America, we do not have a community in America, unless you can point it out to me, that knows about the health of its citizens. We know about the disease of our citizens based on actuarial data or hospital data. We don't know how healthy you are. And in our country, it's up to you as an individual to pursue it. And we get angry and blame the person if they're not taking care. Oh, lose 50 pounds, quit smoking, get the stress out of your life, and by the way, get rid of that lazy husband of yours or whatever. And do it and at the same time you take this medication to drop your blood pressure. We need models that are not highly educated. And this is the thing I learned in AIHA, that lower levels of education and building a system of outreach with referral patterns back to a system of providers for the disease portion of it is what we're going to get a better bang for our buck, and they all have to do with measuring the reduction of chronic disease by improving these 5 basic skills. One of the things I've learned the most is how these partners themselves are brought together to share what they're doing. And I think you'll agree, you can probably identify, a team comes in from Rwanda and they're like, oh my God, we're the only ones who care about this problem in my home country. And then they start learning from each other who are doing fabulous, unusual, and difficult things in their home country. And they say, not only am I going to go back and get this done, we're going to bring 4 more of your problems or your strategies into my home country next. So the value of what I call patient-centered approaches, neighborhood-based coaches that come out of our churches or out of the only activity centers. When you go into a country that has no paper in the hospital and no roads beyond two or three towns, the rest are paths through the cornfields. That's how they get around to their villages of 10 to 15 families. Well, we have a huge outreach in our country as well. It's called both in the inner city and in its rural populations that aren't getting adequate access to care. So my suggestion is what we're learning is that the access has to be to a system of health prevention or chronic disease reduction, as we're talking about, to get a better bang for our buck, but also to build systems of empowerment that are based on education, that are based on group support strategies, that are coming from the local unit, not the ivory tower of science. Nothing wrong with that, but we have to have both. And with that, I think I'm done with my message. Thank you.
Okay, so I want to move from the village to the globe and ask Robert Orr, how does one, we've heard from Dr. Young that you've got to work at multi-levels and people, and we've heard from Sheila, you have to work together. From Todd, different disciplines in science and medicine have to work together. How do you get the world to work together to improve health?
I really like the way this panel has worked out, from the stem cell to the lazy husband to the globe. It's a little bit for everybody. It's perfect. It's good to stretch our brains. Sometimes we're going to all get out of here feeling like we've had a real workout. My job at the UN is to be the, if you will, the professional horizon scanner. What are the problems in the world that we aren't dealing with that if we mobilized ourselves properly we could deal with? Not the crisis that my colleagues deal with in Syria or the crises that come at us in every part of the world, from tropical storms to wars, but what are the problems out there we can all see? In many cases, we know the solutions, but for whatever reason, we aren't actually applying them. And it has been an interesting journey in my almost 8 years at the UN, which problems we have decided fit those criteria, that are problems that are very real, a lot of people are suffering or dying from, that we know the solutions, and that if we mobilize ourselves, we can solve. I think the reason that I'm on this panel is not just to learn a lot from my fellow panelists, but to talk about the potential of the model that we've used to do this on women's and children's health. When we convened about 4 years ago, a lot of the global health experts around a table to say, what are the health problems? We're getting a lot more spending in health these days, but we're not necessarily getting all the health we could out of that spending. While we have a rising tide, what should we be directing people's attention to get the most results from this trend? And it was women's and children's health that everyone kept coming back to say, again, this is the most straightforward. We know the solutions. We know which target population. We know where they are. We know how to do this. And so as a layperson in the room, I kept saying, okay, if we know all of that, what's stopping us? Over the last 2 years, basically, we have launched a global movement on women's and children's health using all of the existing networks of organizations, countries, governments working on women's and children's health. it is amazing to think, but that of the Millennium Development Goals, it was women's and children's health that were lagging the most. Of all the goals that our world is pursuing, you would think the most basic, starting with maternal and child health, would be probably moving the best. In fact, it was moving the most slowly. And so we asked the questions, dove into this, and in 2 years, and the report will be made official here in just a couple days next week, we have mobilized over $20 billion in new and additional money, audited new and additional money for women's and children's health in 2 years, $10 billion of which has actually been dispersed. I'm blown away by this figure. I did not expect this when we started to try to do this. We started from the premise we need more money for health and we need more health for the money. And so we looked at both sides of this equation, and I thought even if we can squeeze a lot out of more health for the money, I didn't think in this environment we were going to be able to squeeze much more out in terms of more money. In fact, it's very interesting. Where does the money come from? When this is made public next week, we'll see the bulk of the money is not coming from your traditional donor agencies of northern governments. It's coming from developing country governments starting to invest more in the health of their own population. It's coming from companies. It's coming from mobilization of civil society, large amounts of money from mobilization of civil society in the developing world and the developed world. And what we've seen is by pulling all these groups together, we have had an upward spiral instead of the classic downward spirals. Everyone is seeing progress. They're seeing other partners in the room. They're saying, wait, we actually can solve this. And if I put some money in as a government, you companies will come in to support this. Oh, and civil society will actually help deliver this. It has created a virtuous cycle. Not all is perfect. We have learned a lot in the last couple of years from this all over the world. But the fact is we are moving up, and we're moving up fast, and we're seeing results. We are saving lives. Our original goal was to save 16 million lives of targeted populations of women and children around the world by 2015. Starting 2 years ago, I think we will exceed our expectations, it looks like, if we're looking at the data, if the data holds for what we're seeing so far. This model, you talked about in the initial kind of request on budgets and on things like NCDs, which are normally thought of as the other end of the spectrum to what we're focused on in women's and children's health, kind of the young versus the old, the diseases of the rich versus the diseases of the poor. What's very striking, to your question of what keeps you up at night, I'm actually kept up by both ends of the spectrum. These totally needless deaths that are so inexpensive, so easy to solve, that we haven't been solving. Now we're getting some purchase on that. But I do stay awake at night on the NCD equation. The fact that we tried to have a major summit, or we did have a major summit on chronic disease, on non-communicable diseases, and it took months to convince many from the developing world that they had to worry about this. The fact that these governments were totally unaware that this was not the diseases of the rich and the lifestyle of the Western world, but that increasingly and at an accelerating rate, a dangerously accelerating rate, this is going to be one of the problems that huge parts of our global population are facing without necessarily the resources and the systems in place to deal with it to the extent that even that we have in the developed world. So I'm kept awake by both. The underutilization of our potential on the easy things to solve that we know, and on the, call them these tectonic trends or tectonic shifts that are happening in the world that we're just even starting to begin to think about. But I'm actually quite heartened. I don't get to hear researchers who work on regenerative medicine very often. I don't get to hear about autism very often. I do feel like it's pulling people in the room that don't normally talk to each other. I've already jotted a number of notes about things I want to, kind of threads I'd like to pull when I get back to my office on pulling some of these things together, because the communities that kind of stick together too narrowly, we're missing so many of the solutions that are quite evident. And if we just got a little more creative about who we're mixing in a room and how we're focusing on a given problem, I think the solutions are truly out there for the taking. Thank you.
Let me just make a quick comment, and that is, there is a connection between what you're worried about in kids that is at least biologically clear and chronic disease, and that is malnutrition and poor environmental circumstances early in life turn out to lead to early death and disease. So this is a continuum. Let me ask a question of everybody, and then we will end with what keeps everybody else up at night. You're all pretty optimistic, whether it's at the level of stem cell treatment, identification of opportunities for new drugs and diagnostics, or that we know enough to go into very strange and remote places, and what we think we know will work almost everywhere. There was something called gene therapy that we heard in the newspapers a little while ago that was going to cure every damn thing in the sun. Science has promised often more than it can deliver. How do you maintain a balance, or do you think this is not an important question? Todd?
I think it's a very important question. It is a balance because, first of all, this is, I guess if you ask a scientist anywhere, anytime in their career, they'll always say, "This is the most exciting time." And so, you know. Well, yeah, because we didn't know it so much before. But I mean, but it's really true. I think that technical innovations, some of them of which have been discussed here, in terms of stem cell biology, in terms of genomics, in terms of understanding the biome, in terms of understanding the effect of early childhood and nutrition, et cetera, on how we all turn out later. It's all coming together. I mean, there's tremendous opportunities. But of course, like anything, so what I think that needs to get out there, that needs to be understood in the public. The public has to appreciate that it actually does pay off to support this, for example. On the other hand, that's tremendous potential. And like any of this, the more you know, the more you know. And there's tremendous challenges. I'll come back to one of those challenges when I talk about what keeps me up at night. So I think it's very important to be rational, truthful about the promise, about the potential, but truthful also about how these challenges have to be met before they're actually translated, because it's not only just dangerous, but it's also just really, really hard.
Dr. Lewishka.
Well, I'm going to kill two birds with one stone and just go into what keeps me up at night. And it's going to dovetail from what Todd said. And I think one of the failures of the biomedical research community in general, or maybe not failure, but something we should and don't engage in enough, is public education and outreach. And you know, I can give you one example where some time ago I gave a small talk, very easy to do, to a community group about stem cell research, and I've had people come up to me afterwards and say, when I came into this room, I was 100% against stem cell research because I thought it was unethical, and you've changed my mind. And I came away from that thinking, how easy was that, and how much good can that do to educate the public, and who better to educate the public in stem cell research or any kind of cancer research than the people who do cancer research and stem cell research. So it's easy to do. We don't do enough of it. I worry about that. That keeps me up at night because getting back to gene therapy, there was a death of a patient. And this set the field back, I think, many, many years. And it took probably at least 10 years for it to recover. There was a time there where the phrase gene therapy, nobody wanted to be associated with gene therapy. And what I worry about is that we will have something similar in the stem cell field, God forbid. But, there's possibilities of that. And this all goes to also dovetails with, making false promises, and or rather not making false promises. And, sad to say, I hear people in the stem cell community, making claims that I think are, frankly outrageous and very, very irresponsible. And this sets the stage for failure, I think. So, and how do we prevent this? Well, I think it does come down to education. It does come down to telling the public and informing the public, what are reasonable expectations that are deliverable within, some finite period of time, and which are not. So if somebody says, I'm going to use stem cell research to grow a new heart or a new liver, well, this may well happen at some point, but, I wouldn't want to hold my breath, and I certainly wouldn't want to tell the public that, we're on the verge. I mean, it's one thing to make a heart muscle cell. That's fairly straightforward from stem cells. It's a whole other issue to make an organ that functions in 3 dimensions and well, in 4 dimensions, really. So education, more engagement by the research community with the public. This cuts across all areas, including something that's not related to what we do. So, for example, evolutionary biology, evolution. I mean, who better to explain evolution or what the evidence for evolution is than an evolutionary biologist? I mean, but we do not engage enough. And what keeps me up at night is, I don't know how to create an infrastructure, something in between, the research community and the public that could serve as a structure for, outreach and education. And then the second thing that keeps me up at night is more mundane, and that's the sad, sorry state of funding for research. The two are not unrelated, by the way, because it's the public that pays the bills for our research, whether it's federal funding, state funding, or philanthropy. It's always the public, and why we don't reach out more keeps me up at night on many levels.
So one of the trends in medicine is called translational medicine, and we talk about that moving from the bench to the bedside. There's another almost more important part that you were referring to, which is translation of the arcane stuff that we do to make it clear to the public why we do it and what the benefits are. And you'll note that almost all newspapers are cutting back on their science editors. So at a time we need greater communication and translation that the public everywhere can understand, we're getting fewer people to do that. Why don't we just run down the line and ask what keeps everybody else up at night? Yemi?
One big thing is having tools to understand the modalities of the systems we're dealing with. 10 years ago, the Human Genome Project had a promise: we're going to cure all diseases known under the sun with the new human genome. Well, if the technology costs $3 billion, that's not going to happen. But now it costs $5,000, and we can use it to better understand the microbiome, to better understand the systems that we're dealing with. What keeps me up at night is basically, how do we change the clinical paradigms that have existed for decades as new innovation enters into a more usable setting. So thinking about how do we change, practice that has been tethered to culture for decades, or PCR for decades. How do we change that to more innovative technologies? That's
Great. We're running short on time, so I'll ask everybody to be brief.
Okay.
Larry?
Okay, I'll say 2 things that keep me up at night. One that keeps me up with excitement has to do with my own research. This is I run a lab, and I am doing work trying to understand how chemicals act in the brain and neural circuits act in the brain to create behaviors and social engagement and things like that. And I think that we have to recognize that individual scientists around the country, many of them basic scientists, are very, very excited about their own research and their own, the things that they are doing, and that keeps them up with excitement. The second thing that keeps me up is recognizing that and trying to figure out how can we take these individual scientists that are asking these individual questions and bring them together to ask these bigger questions of how can that be transformed and translated into treatments for human disorders. And I think that that's something that leaders in science have to do, is to rally people together to make that basic science turn into treatments.
Sheila.
I think the promise that I see is with the people. The promise of the people through access, and I forgot to mention this earlier, through access to information through our technologies. If you have the basics of healthy behavior choices in terms of all of the difficult things it takes to change your behavior, it can be on an iPad, and a health coach can be distributing them. And as long as you set your health goals and then track your improvement, I don't care if it's the 8-year-old having to take 3 green vegetables a week, and they're not going to get in a game unless they start tracking and trending their own health improvement behaviors. We have the technology and the information available today. The second model is something brought up I think is really powerful, is we need new models of financing. I'm thinking about and I'll be very brief, a project I'm working on now, Planet Water, of putting towers of water attached to elementary schools throughout Indonesia, Cambodia, Thailand, and using an artificial kidney, a Dow Chemical artificial kidney that I tested as a young nurse in the Bay Area, which takes out all the nanomicrobes and cleans it. So here's the difference. How are we going to build in our research to track it, to document the reduction of waterborne diseases, the increase in cognitive behavior of the kids, as well as the translation of clean water behaviors at home? And it's by adding $500 to an $8,000 water tower with everyone that's installed, using a lot of private investment, frankly, and that's beginning to pay for our research, which is going to be an ongoing, and I want to send teams of student researchers with faculty who've never been, and this is my last issue of concern, is the silos we keep replicating in our academic centers. We keep building more and more silos with deeper and deeper specificity of our expertise, and do not create opportunities to work across to solve anything. So,
Todd?
Keeps me up. This is a little scary because it's kind of a nightmare. But we talk a little bit about personalized medicine. Your disease is not the same as my disease. Cancer is actually a chronic disease in some ways. We're constantly getting cancer. Probably cancer cells are being shed, but we're fighting them off all the time. Occasionally one seeds. By the time we know that it needs to be resected, it's actually a very complicated disease. So not only is one person's cancer different from another person's cancer, but in that cancer are many different microcancers, because the cancer is itself evolving over time. So a specific drug that's developed to fight that cancer may not target only some subsets of that. So personalized medicine down to disease-specific medicine. It's exciting, but it's a challenge.
Let's throw it open to the audience to ask this wonderful panel questions that come to mind, please. And could you wait for the mic so we can record that?
okay.
The mic has just come. Yes, thank you.
Hi, good morning. And the point I'm making is that our healthcare system worldwide is literally taking care of sick, and it's a sick factory. We're talking about sick factory where more medicines are made, more patients are developed, more doctors make money out of it. And what we need to do is incentivize people who are healthier or getting healthier, from the students, from the children, and from the families. That's the main message I have.
Thank you.
I will work on it. Cheers.
So that's what we think we're doing in public health, which is preventing people from getting sick, as opposed to, right. And to go back to what percentage of the $2.7 trillion spent in this country actually goes in prevention relative to treatment? Maybe 1%.
Yeah.
It's not the most cost-effective investment. Please, questions?
Sorry, very
Oh,
quickly.
I'm sorry.
I just had one question.
Matthew?
I guess two questions about really funding models. Yesterday on the genomics panel, there was a comment made by William Hasseltine, who indicated that big pharma was in fact broken, or the system of bringing drugs to market was broken. And certainly in sort of a move towards personalized medication, you have smaller populations, a smaller base, and large companies won't want to invest in a sort of smaller base drug. So how do we create a new financial model? Maybe Yemi and also Ihor can speak to that about bringing new innovations to, I guess, developed markets in terms of very specific ways. And the second model, or the second question I guess I have for Robert and Sheila is, how do we move away from a strictly donor-based model for developing world type issues? So how can funds be generated more effectively and transmitted more easily, in fact drawn from a broader base? Because I think, Robert, you said you were surprised at how much money was sort of given, but is there a different way that can be more immediate?
Who wants to comment on how we can fix the broken pipeline and costs? The major costs in drugs is clinical trials. You know, the vast majority fail at some time of all these great new scientific ideas. How do we pay for that? How do we take care of the risk? And Yemi would probably have the best shot at that.
Yeah, I'll take a stab. Well, I think, just jumping up from what Todd had mentioned, you know, as we look at the promise of personalized medicine, the goal is that really the cost of bringing a drug to market will be reduced. How? By really limiting, one, the patient cohort or the size of the clinical trial, and even the size of the development of the drug. Why? Because it's narrowed to a certain patient population. And we believe that because it is narrowed, it's tailored, that really the efficacy in this patient population will be higher. So really instead of developing a drug for an entire population, having a really big clinical trial, and then in phase 2 find out it's toxic, well, perhaps if we narrowed it down to a specific population, you know, we had a narrower clinical trial, which means the cost is less, the time to market is less, and also from an investor's perspective, they get their return in a couple of years instead of a decade. You know, those are models that could eventually be put in place, so it has promise as we enter into the era of personalized medicine.
Anyone else want to comment on that part of the question?
I want to just cite one of the bullets in one of your slides, Barry, about Berwick theorem, who has said for 20 years that a third to a half of the money we spend, the 2.7 trillion, is probably wasted, not effective, and not necessary. The problem is political will for shifting it. That's the problem. It's not Obamacare or Romney care. It's care that 3,000 of our 5,000 hospitals know actively how to improve quality, reduce cost. But they don't want to, until the incentives change and clearly shift to more cost-effective risk reduction models, which we know how to do. It's the political will. The second point had to do with the piece of, do we know how to identify those high users? Yeah, we do. They have 10 to 15 specialty physicians. They have 3 hospitalizations here. We know how to identify them, and 1% of Medicaid population, and you can even identify that state by state, use 25% of the revenue. We could focus clearly on them, but oftentimes they're poor, they're not insured, they're minorities, they're in new immigrant populations, and there's no incentive for the insurance companies to move into that population. So it has to do with political will, incentives, and shifting. I think we have plenty of money. It's the realignment.
So how do we shift the incentives from the usual category of donors to whom and how? Robert?
If I could dive in on that, I think that the new financial model has to recognize that we need incentives up and down the chain, starting with the individual. They have to have an incentive structure that makes sense. Poor people spend a disproportionate amount of their money on their health. They just spend it at the wrong time. When one family member gets sick, 20 family members are bankrupted because that one sick individual has to suck in all the capital for the last 6 months of their life. So if we start at that level, what we've seen on women's and children's health, that the contributions from individuals and families and communities are definitely there. They're just not allocated in the most effective way. but that there needs to be an incentive structure for the outside players to kind of join that equation. And it is fascinating to me, working on the women's and children's health side, to see what something as, if you want to call it airy, as the notion of hope changes the equation. When people see that they can live longer, they live their life differently. A person who thinks their natural lifespan is 20 years lives their life one way. If they think it's 40, a different way. If they think it's 60 or 80, very different life. So they change. And so taking the hope of high-tech medicine, I've been in a health post in rural Ethiopia to a slum in Dhaka, Bangladesh, where high-tech for them is the blood pressure cuff. And so what, you can see inside my body with this thing? So if we give some hope to say, yes, if you do certain things, you can live longer, you will see your children through school, all those things. And it is this, the power of knitting these different communities together that I'd say, hope may apply at the village level. It also applies in the corporate boardroom. When you see that there's actually hope that some of these investments could pay off for you, you do things differently or pay off in different ways. So it is bringing these communities together and giving them they all have different funding incentives. But when we bring them together, everyone is getting more out of this than they're putting into it. I think it's a model that we're just developing 2 years in. I think it's very powerful that could have application more broadly.
Please, question here, microphone.
Well, I think it could. I don't think it has. We're just now incentivizing hospitals and physicians' office practices to have a common record keeping electronically to save. That's one of the big costs of the wasted care. I don't know that you had an x-ray last month, and you maybe have had 3 in the last 3 months, and so making that information available will reduce costs and improve the quality, frankly. But it is the hope of reaching into villages, frankly, satellites and cell phone. The cell phone access is one of the highest in the world, and you can track health behaviors using cell phone. The system I've been looking at, working with, actually out of Sioux Falls, South Dakota, has gone into Native American reservations and worked on reducing diabetes care. And the comment about hope is that when one of the, and it shows me the value of coaches, one of the abilities to write down what you eat and then it translates into your nutritional daily requirements per day, per week, per month, up and down, plus an advisor about what to eat. The woman said, not only you mean I don't have to die of this disease? No, you mean my son doesn't have to die of this disease if I start tracking my food intake. And they were able to get a lot of people off insulin in the reservation just by information. So telemedicine, and telehealth and telemedicine are different than just information connections through the internet. All of it could be done. I think we could be doing robotic surgery in other countries, truthfully, because we have surgery residents training on how to do the robotics, and anybody who does a game uses the robotics. I mean, kids know how to use robotics more than professionals do, believe me. So it's a combination of both, I think, the promise.
Larry, do you want to comment? No. Okay, we are somewhat over time. I would say that it's been a very interesting panel. It has covered from the genes to the globe, which is hard to do in an hour and 15 minutes and a little more. I think that there are real messages, which is the potential of science is enormous. The limitations of science are not so obvious, and integrity and honesty is the only hope we have for the trust that will be required to have people entrenched, whether it's shamans in villages or HMO directors here, to agree to change to make it a more equitable, affordable, and quality system. With that, I thank the panel, and I thank all of you for staying through.
Pleasure.